Augmentation is a surgical procedure to enlarge a body part. Augmentation, lengthening, mandibular body or angle, prosthetic material. The physician may use an intraoral approach or may make skin incisions extraorally below the body or angle of the mandible. The physician dissects tissues away and the bone of the body or angle is exposed. A synthetic material is placed on the mandible to augment the contours. The material is secured with screws or wires. The incisions are sutured simply. Augmentation, mandibular body or angle, with bone graft, only or interpositional, includes obtaining autograft. The physician uses a bone graft to augment the body or angle of the mandible. The physician harvests bone from another site on the patient's body, most commonly the rib, hip, or skull, and repairs the surgically created wound of the harvest site. The physician may use an intraoral approach or skin incisions. The physician dissects adjacent structures away and the body or angle of the mandible is exposed. The graft is placed on an area of the body or angle to augment the contours. The graft may also be placed between portions of bone of the body or angle, interpositional grafting. The graft is secured with screws or wires. The intraoral incisions are sutured simply. The extraoral incisions are closed with layered sutures. Outflow tract augmentation, gusset, with or without commissurotomy or infundibular resection. Cardiopulmonary bypass is initiated. The right ventricular infundibular muscle is opened and the obstructing muscle bands are cut out. The valve may also need to be opened. If so, the valve is cut open. The hole in the right ventricle is closed with a patch of pericardium. Cardiopulmonary bypass is discontinued when heart function returns. Report 33,478 if the operation if performed with a gusset, with or without commissurotomy or infundibular resection. Outflow tract augmentation, gusset, with or without commissurotomy or infundibular resection. Cardiopulmonary bypass is initiated. The right ventricular infundibular muscle is opened and the obstructing muscle bands are cut out. The valve may also need to be opened. If so, the valve is cut open. The hole in the right ventricle is closed with a patch of pericardium. Cardiopulmonary bypass is discontinued when heart function returns. Report 33,478 if the operation if performed with a gusset, with or without commissurotomy or infundibular resection. Lengthening of palate, and pharyngeal flap. A midline incision through the soft palate is made to expose the posterior pharyngeal wall. The physician incises a flap from the posterior pharyngeal wall through mucosa, submucosa, and muscle. This flap is sutured to the soft palate. Advancement flaps utilizing posterior palatine blood vessels are used to lengthen the soft palate by suturing techniques that increase the anterior-posterior length of the soft palate. All remaining midline incisions are sutured in layers. Lengthening of palate, with island flap. The physician uses mucosal island flaps to lengthen the soft palate. Incisions are made in the palatal mucosa adjacent to the alveolar, tooth-bearing, bone. The mucosa is elevated and loosened from the bony palate. Advancement flaps utilizing posterior palatine blood vessels are used to lengthen the soft palate by suturing techniques that increase the anterior-posterior length of the soft palate. All remaining incisions are sutured in layers. Lengthening of hamstring tendon, single tendon. Multiple tendons, one leg. Multiple tendons, bilateral. The patient is positioned prone, lying face down. The physician makes a 7 to 10 cm longitudinal incision beginning just above the popliteal crease and extending upward. Dissection exposes the hamstring tendons. The tendon sheath is divided and the tendon is incised transversely at 2 levels, 3 cm apart. The physician flexes the hip while the knee remains extended, causing the tendon to lengthen. The tendon sheath is closed. Lengthening of tendon, extensor, hand, or finger, each tendon. Lengthening of tendon, flexor, hand, or finger, each tendon. The physician incises the overlying skin and dissects to the tendon. The physician performs step cuts to lengthen the tendon. The incision is sutured in layers. Report each tendon separately. Tendon lengthening, upper arm or elbow, each tendon. The physician lengthens a tendon of the upper arm or elbow. An anterior curvilinear incision is made, for example, over the anterior elbow to lengthen the biceps tendon. Dissection exposes the distal biceps tendon. The biceps tendon is divided by Z-plasty and stretched into extension, causing it to stretch and release to a lengthened position. If the elbow joint capsule is thickened, the physician may elect to excise this part of the capsule and any fibrous bands or bone spurs in the anterior part of the elbow joint. A drain is inserted into the wound and the incision is repaired in layers using sutures, staples, and slash or stri strips. The elbow is placed in a splint or cast in an extended position. Lengthening or shortening of tendon, leg or ankle, single tendon. Multiple tendons, through same incision, each. The physician makes 3 incisions on the lateral side of the foot centered over the sinus tarsi. The physician exposes the extensor digitorum brevis tendon, and reflex it distally to expose the anterior part of the talocalcaneal joint. The calcaneocuboid joint is identified and all tight surrounding structures are released. A second incision is made on the medial side of the foot centered over the prominent head of the talus. The physician releases all tight structures on the medial and dorsal aspects of the head of the talus and the navicular. The anterior part of the talus is freed from its attachments to the navicular and calcaneus. If the peroneal, and extensor hall UCI's longus and extensor digitorum longus tendons remain contracted, the physician lengthens them by Z-plasty. A third incision is made on the medial side of the Achilles tendon, lengthened by Z-plasty. The physician inserts a Steinmann pin through the navicular and into the neck of the talus to maintain the reduction. The wound is closed in layers in a long leg cast with the knee flexed and the foot in proper position. The Steinmann pins are removed in 8 weeks. Lengthening or shortening of flexor or extensor tendon, forearm, and slash or wrist, single, each tendon. The physician lengthens or shortens a flexor or extensor tendon of the forearm and slash or wrist. For lengthening, the physician makes an incision in the forearm and down through the tissues to identify the affected tendon. The physician may make a series of small, equal depth cuts spaced on opposite sides of the tendon to allow it to stretch without tearing through. An elongated Z incision may be cut in the tendon and the ends of the long half of each section are sewn together, or an oblique incision is made across the tendon and the ends are slid apart until the pointed tips meet, which are sutured together. Several methods are also used to shorten a tendon that has become too long to function properly. A Z incision may be made in the tendon and the two short sides of the Z brought together and reproximate. The tendon can be doubled over on itself with a small fold and sutured. A wedge-shaped piece may be excised and the two ends sutured. The soft tissue is closed in layers and a bandage is applied. Shortening of tendon, extensor, hand, or finger, each tendon. Shortening of tendon, flexor, hand, or finger, each tendon. The physician incises the overlying skin and dissects to the tendon. The physician removes a section of the tendon and sutures the ends back together, shortening the tendon. The incision is sutured in layers. Report each tendon separately.